for his research innovations in Malaysia. It is our privilege to have you here, sir. I request you to share your experiences with us. Thank you.
Thank you, Rima, for the kind introductions. So before we're going to start our presentation, I just want to confirm you whether my audio is clear for you or if you have
Yes, sir.
any disturbance. Okay, clear.
We
Thank
can
you.
hear. Yes.
Okay, I try to share my slide first. Can you able to see the slides, everyone?
Yes, sir.
Ms. Rima, can you able to see the slides?
I'm not able to see it, sir.
We can see it.
Yes,
Is
now I
everyone
can
able to
see
see?
it. Yes, sir.
Okay,
Yes.
that's good.
Yeah,
That's
it's
good. Fine. Okay, so can I start now?
Sure, sir.
Okay. So good afternoon, everyone. So first of all, I would like to thank Dr. Raghuram for giving an opportunity to share of my knowledge to the fellow therapist and also the budding therapist of Sri Ramachandra Medical University. I also thank Sri Ramachandra Medical University for giving an opportunity and accepting my proposal. So without further ado, so we can enter into the topic. So good afternoon, everyone. The topic we're going to be discussed today is like a very unique topic. It's like low vision rehabilitations. So we're going to promoting the low vision rehabilitation in more on the OT perspectives. So this is a short profile. Mrs. Rima has then already introduced this, and I will have a few membership related to the different associations in the different part of the world. So today learning objectives, we're going to be learn more about the visual impairment in the concern of an older adults. And we're going to study about anatomy and physiology of the eyes and various eye disease and what do you mean by refractive errors. Understand how we're going to implement the ICF model and also OTPF, occupational therapy practice framework to the low vision rehabilitations, and understand the evaluation and intervention process for the low vision rehabilitation. So this is the objective we're going to be achieved at the end of the lecture. So before we go into this one, so I'm going to continue the lectures. So if you have any doubts, so please note it down and you can be asked at the end of the lectures. So that's why I can able to continue the lectures without any kind of disturbance. So it will be easy for you to understand. So we can have a discussion after the end of the sessions. So first we have to be understand about the prevalence of this blindness and the visual impairment. So according to WHO, globally there will be have 2.2 billion people having the visual impairment or blindness. So in that 1 billion people who having a visual impairment, which has been getting prevented, it means they will have the correction of the errors and they can get all kind of treatment implementations related to the visual impairment. But 1 billion people who having a visual impairment, they're not able to address this refractive errors. So they didn't able to get the appropriate kind of treatment or appropriate types of glasses to correct the visions, because they can be classified as a moderate severe visual impairment. So it's like 1 billion is a huge number. So it is mainly due to there is a lack of awareness about this visual impairment and what kind of an rehabilitation process can be happen for this type of populations. If you see in that 1 billion, majority of the people who are affected with the visual impairment is over 50 years and above. And sometimes the term low vision has been interchangeably used as a visual impairment. And according to ICD-11 of the current classifications of visual impairment, they remove the term of low vision and they will include the visual impairment. And this visual impairment has been classified into mild, moderate, and severe category. So we have to know the different terminologies which has been used by the ophthalmologist and optometrist, because as an occupational therapist, we're going to interview with the ophthalmologist or optometrist. So it is important for us to understand about their terminology. So this, if you know their terminology, it is easy for you to make communications and understanding the treatment process. So for that, we have to know the definitions of related to the low visions. So what do you mean by low vision? Low vision is a visual impairment which cannot be corrected by the regular treatment methods. Maybe you can able to give the glasses or you can correct the refractive errors, but still the patient is having some kind of difficulty in participated in the daily life activities. So that is called as a low visions. So it is a definition given by the National Eye Institute. Next is you have to understand the definition of the blindness. So here we will be targeting more about the legal blindness, because when you say it's a legal blindness, then only the patient can able to get the reimbursement process, which can be provided by the many of the insurance company or by the Medicare companies. So that's why the term legal blindness has been used. So according to the US consulate, the legal blindness is considered as the individual who having the visual acuity of 20/200 or worse than that, then they call it as a legal blind. And they also concern about the visual field. If the person having a visual field 20 degree or less than 20 degree, also eligible for as an illegal blind, and they can go for the getting the reimbursement. So the definition of the blindness, which will be varying from country to country. So if you take in India, still India is also having the visual acuity range of 20/200 as a legal blindness, but in India they will call as an employee blindness, or they call as social blindness if a severity will be getting increase. If you concern about the WHO, the legal blindness will be considered as a 20/400 and with the visual field of 10 degree or less than 10 degree. So this is the different definitions of the blindness. So next is the color visions. Color vision is the ability, you can able to see the different colors and identifying the colors. If you're having an inability to identifying the color, then it's called as a color blindness. So as I am going fast, or you can able to follow me. Is it okay if I go in this tempo? Is okay? Miss Rima, can you?
Yes, sir.
Okay, thank you. So next is the definition for low vision rehabilitation, which is given by the ophthalmologist. So it is a service mainly designed to help the people who having a difficulty in the visual field or visual acuity, and they will compensate to do the daily functional activity at the optimum level to live the sufficient and good quality of a lifestyle. So if you see the definition of this low vision rehabilitation, which is more related to our OT philosophy. If you think about our OT philosophy, mainly we have to be target about making our patient has been functionally independent to the optimum level, and we have to be bring the quality of life for our patients. So the definition of an low vision rehabilitations and OT philosophy has been interrelated together. So the American Occupational Therapy Association says that low vision rehabilitation can be given by the OT in order to enhancing the activities of daily living and to make the patient to be do their participation, health and well-being, and maintaining the quality of life, but also the activity they want to do and also they need to do. If you concern about the Sentinel Vision, the 100-year celebration of an occupational therapy in USA, they see this low vision rehabilitation is one of the growing practice area for an occupational therapy, and they think that low vision rehabilitation is having a scope for an occupational therapy. So this is the classifications of the visual impairment. according to ICD-11. So the current classifications. The patient who having visual acuity 20/40 until 20/40, it means they don't have any kind of vision impairment. But if the visual acuity will be worse, more than 20/40 or 20/70 is called as a mild vision impairment. 20/70 to 2200 is moderate, and 2200 to 2400 is like a severe impairment. If it is below the more than 2200, then they can come under the category of blindness. They have different category in the blindness, is like mild and moderate, and the total blindness or profound blindness. When you say there is no light perception, whether the brain is not receiving any kind of light perceptions, then it's called as a total blindness. So this is the classification. As today's concern, we will be going to be see only related to mild vision, moderate vision, and the severe vision impairment, because this is the category which will be inverted into the low visions. According to the American Occupational Therapy Association and Occupational Therapy Framework, so the two important things we have to be considered is our body function and the body structure. So whatever the area you are working, so you need to be know about the body function and body structure of that particular part. If you're working under the musculoskeletal system, or if you're working under the neurological system, it is mandatory for us to know about the structure, the anatomy, and also the physiology of the particular structure. So here we're going to be concerned about the vision. So it is mandatory for us to have the knowledge related to the anatomy of the eyes and also the physiology of the eyes. So if you see the anatomy of the eyes, so we're going to know the different parts of the eyes. First one, you're going to be see the cornea, which is the outer layer, and this is the part which will be focusing the object in the environment, and it will be transferring the informations to the lens. So behind the cornea, you can able to see the anterior chamber. So this anterior chamber will be filled with the liquid. We call it as aqueous humor. So after the anterior chamber, you can able to see the iris. So the iris, which is the outer layer structure, which will be surrounding the pupil. And we have the pupil. The pupil is a part which will be allowing the amount of light which can be enter into the lens. So the pupil can able to constrict or dilate. So by means of constrict, it can able to sending the sharp images. By means of dilate, it can sending the images which will be not very sharp or blurred sessions. So these people can able to control the amount of light which can able to enter into the lens. So after the people, you can able to see the lens. So where the light perception of the images has been fall down in the lens, and the lens can be transforming the information straight to the retina. So the retina is the part which will be concerning the images, and the image will be fall on this retina. And from the retina, the image has been converted into the light sensor by means of the receptors. We call it as a photoreceptors. These photoreceptors will be carrying this light sensor through the optic nerve, and it will be passed through the optic nerve. Then it can be transferring into the visual cortex, which has been presented in the occipital lobe. So the optic nerve is a structure is responsible for transforming the informations from the eye to the visual cortex. And in the center of the eyeball, we have the gel-like substance, which is called as a vitreous body, which can be filled with the vitreous humor. And another important structure which has been presented in the posterior aspect of the eye, we can see is like a macula. So inside the macula, we have the fovea, the deep depression inside the macula, we call it as a fovea. This fovea is responsible for getting the sharp visions. And if you see the cross section of the macula, you can see they will have the retina, and behind the retina we have the choroid. The choroid is the structure that will supplying the blood to the retina and also the nutrition substance to the retina. And after that we have retinal epithelium cell, and which will having this rods and cones. And the rods is a structure which will carry the informations and of the images, and the cone which will carry the color sensations. So these two photoreceptors will be combined together and taking the informations to the brain. And we having the sclera which will be covering the whole eye, and it will giving the structure of the eyes and to maintaining the structure of the eyes. Apart from that, we having the ciliary muscles, the ciliary muscles, which will be holding the lens and help for the constriction and also the dilatations of the lens. So whenever you want to focusing the sharp object or we focusing the near or distance objects. And we having the eyelids, which will protecting the eyes, and we have the tear duct, which will be producing the tears, and it will be removing all the debris which has been presented in the eyes, and it will be keep the sclera of the eye should be more wet. And we already know we have the muscles, 6 muscles which are surrounding the eyes, which will be responsible for the eye movements. We have the lateral rectus muscles and medial rectus, and also anterior and superior oblique muscles also. So this is the anatomy of the eye. As an occupational therapist, when you're dealing with low vision rehabilitation, so we must know the structure of the eyes, because any damages causes in this structure, then it will be leads to the poor physiological functions, and this physiological function will be affecting our activities in the limitations. Then our activity limitation will be restricting our participation in the doing the activities. So it's like go in a hierarchical process. So it is mandatory for us to know the anatomical structure first. So next we have to understand about the physiology. So maybe a few of the participants here will be the practitioner and may having many years of an experience. So for them, it will be like a kind of refreshing the informations. But for our budding therapist or the students, so it will be very good informations. They have to understand more about anatomy and physiology first before enter into any of the treatment modalities. So if you see the physiology of the eye, is comparing to the functions of the camera. So how the camera is function, our eyes will also having the same kind of functions. First, the images which will be fall on the retina, then it has been processed in the retina as a light sensor receptor, then it will carry to the brain by means of an optic nerve. Then in the brain, it will be do the further processing, then we having the perception of the images has been settled in our brain. The same like if you see in a camera, the photo detector, carry the images and it will be stored in the camera memory. Then it goes to the computer, then comes to computer screen, and you can able to see the images. So next we're going to see about the small video regarding the physiology of the eye.
In this vignette, we will learn about visual process. The fundamental effect that light has is that it enables us to perceive the world around us. The role of light in our contact with the environment can hardly be overestimated. And this is possible because of an extremely delicate sense organ, the human eye. In fact, more than 80% of the information we receive from the outside world passes through our eyes. Let us understand the visual process. Our eye functions in roughly the same way as a traditional camera, with a lens that projects an inverted image of the scene. With a lens that projects an inverted image of the scene onto a light-sensitive inner film. In the eye, this film is replaced by the retina and consists of light-sensitive nerve endings. The iris in front of the lens can open or close, like the diaphragm of a camera, to control the amount of light that enters the eye. The opening in the center of the iris is called the pupil. When more light is incident on the eye, the pupil size becomes smaller, and again, like with the camera, the depth of focus, or the distance over which we see sharp images, becomes greater. Here, the light is transformed by a photochemical process into an electric current and transmitted through the nerves into the brain that in turn is saved as visual information. Human eye has the unique properties of sensitivity towards different light levels and the ability to distinguish between different shades of colors. These properties are obtained through the division of work between millions of highly specialized light-sensitive nerve endings known as cones and rods. The rods are highly light-sensitive and are principally responsible for the detection of rough shapes and movement. Cones, on the other hand, are less sensitive to light, but can distinguish colors. In case of low lighting level, vision is by rods only. Some hundreds of rods connect to a common nerve fiber that goes into the brain. However, because of this grouping, the exact position of the light source is not known, resulting in a rather blurred vision. As higher lighting levels, the cones take over completely. Each individual cone, unlike rods, connects to the brain via a single nerve fiber. Visual acuity, or resolving power with cone vision, is therefore far better, resulting in sharper images. Now let us understand the adjustment mechanisms of the eye. The first mechanism is accommodation. Focusing at different distances is achieved by changing the refracting power, or focal length, of the lens. The lens of the eye can contract under muscular control, making it more convex, thus shortening the focal length. This process is called accommodation. The second mechanism we will learn is convergence. We use both eyes to look at one and the same target. To achieve this, we unconsciously rotate our eyes in our eye sockets. We call this convergence. When we look at an object, the lines of sight of the two eyes will intersect at the target point. The closer the object, the greater is the inward rotation of the eyes. The required amount of rotation is a measure of the object distance as noted by our brain. Thank you.
Okay, so the video has been clearly explained you about what is a physiological function, and we need the accommodations and also the convergence property in order to bring the object nearer and also far away to get the sharp images. And next we have to be understand about the visual pathway. So where the information has been carried from the eye, it goes to the brain. So if you see the physiology of this visual pathway, so we have two fibers which is called as a nasal fiber and temporal fiber in the eye. So if you see the right nasal fibers and also the left temporal fiber, which will be bringing the right visual field, and the right temporal fiber and the left nasal fiber will bringing the left visual field. And this information has been carrying through the optic tract, and it has been getting intersected in the optic chiasma. Then the right visual field, which will be goes to the left part of the brain, and the left visual field will be go to the right part of the brain. So after it getting crossed in the optic chiasma, then it has been entered into the lateral geniculate nucleus, which is present in the thalamus. And from the lateral geniculate nucleus, it has been goes into the visual cortex, which by means of an optic radiations. So there will be some intersection function is happening from the lateral geniculate body. Some of the information will go to the superior collicus, which is present in the midbrain. And here the informations like the movement of the eyes and the object tracking has been getting maintained, and that the information has been sent back to the pulvinar nuclei, which has been presented in the thalamus. So we have to be understand about this process of visual pathway, because if there is any damages happen in the structure of the eye, then it will have some visual acuity, visual field problems. If there is any damages which has happened after the eyes, and maybe in the optic tract, or maybe in the subcortical structure, or maybe in the cortical structure, then it may lead to get some visual field deficit or visual perception problems, which will be most commonly get when it is after the eye structures. So in order to understand the pathology, we have know the very good anatomy and also the physiology of the particular structures. So next we move on to the different components which has been considered in the visions. So one of the main component is like an visual acuities. It is the level of detail what the person can able to see in the environment from the particular distance. Next is the refractions. It is the evaluation of an optical system, whether you will getting the image of that particular refraction of the particular image is exactly on your retina or not. Next is the visual field. It is the total area one you're going to be see in a single view by keeping the head in a center point without turning the head and turning the eyes. So that's called as a visual field. Next is the contrast sensitivity. It is an ability to distinguish the different shades like a light color and the dark contrast, which has been present in the similar colors. For example, if they're giving like a blue and blue, you can able to see the difference between the the blue and blue. So if you have this ability, then your contrast sensitivity is good. Suppose you're having a difficulty in differentiating this two type of colors or the two type of contrastivity, then it means that you're having some contrast sensitivity problems. And next is we're going to see the light modulation. So light modulation is the ability to adapt to changing the light conditions. For example, you will be entering in your house after in the bright sunlight, you enter into the house. So there will be a sudden changing in the light. So you can see there will be some kind of a darkness or glaring situation when you enter into the different types of light. Your eye will take some time for getting into the accommodation to the particular environment. Suppose suddenly the current will be off and you enter into the darkness, you cannot able to see the environment immediately, but after a few minutes you can able to see the object even in the darkness. So your eye will be able to modulating the light. So that's called as a light modulation. So this 5 components we're going to see in the detail. So first is then visual acuity. The normal visual acuity is 20 by 20. So as per the classification of an ICD-11, that means the person can ability to see the small object, small details in the object from the particular distance. So if you see the client who having 20 by 100 visual acuity, so it means that you will having the 5 times relatively less acuity when compared to the normal person. So if you see what is that 20 by 20 means, the first 20, which will be mainly dealing about the distance, the 20-meter distance, you can able to read the letter size, which will having a 20. So letter size is 20. That means you can able to read the small letter from the 20-meter distance. That means your normal visual acuity. If you can able to read only the letter size of 100 when you are seeing from the 20-meter distance, that means automatically you will be 5 times less acuity you are having. So if the person can able to read the letter only 100 from 20-meter distance, that means they cannot able to read the letters below like 80, 50, 20 like that. But they can able to read the letter above the 100 is like 150, 200 or 300. They can able to read the letter, but below 100 they cannot able to read. So this we call it as a low visions. So as an OT, we have to be understand about what is mean by these denominations like 2000 or 2200. We can able to understand. Then it's easy for us to giving the treatment for our patient. So we can able to keep the distance of the treatment object within this particular visual acuity where the patient can able to see it. So for that purpose, so understanding about this denomination is very important for an occupational therapist. So usually we will use the Slannon chart for checking the visual acuity, but in the case of an low vision, it is difficult to use a Slannon chart, because if you see the Slannon chart, it can able to detect the visual acuity up to 20 by 200. But the low vision person, sometimes they will have a 20 by 400, 2700, or 20,000. It will be differ. So we cannot able to use the Slannon chart on that particular time. So we have the different types of visual acuity chart for especially used in the low vision client. And vision acuity can able to measured in 2 types. One is on the distance acuity, and another one is by the near visual acuity. So if you see the Slannon chart is mainly based on the distance acuity. So this is a Slannon chart. You can see the 20 by 20 letters. It is very small. The person can able to read the letter from the 20-meter distance. And if the person can able to read this, then it's normal acuity. Suppose the person can able to read only level the meter 3 of TOZ, that means he having visual acuity of 20 by 70. So it's like on low visions. And if a person can able to read only the big letter E, that means his visual acuity is 20 by 200. So that means person is having low vision and also the mild and moderate categories. So we can able to detect the visual acuity by keep the person to reading the letter from the 20-meter distance. For the low vision categories, so we having the faint blown visual acuity chart, because this chart will be measuring the visual acuity ranging from 20 by 1000 to 20 by 20 for the normal. So you can able to see the big letter. The person can able to see only this kind of big letter. So it will come under 20 by 1000, and you can having the various letter denomination with the different sizes. So if the person can able to read the small one is normal, and it will be like a 963, it will be like having a low vision. So we can able to use this Finney-Blunt chart for the person who having a low vision to measuring the distant visual acuity. And the Chronister packet acuity chart, this can also used for the low vision categories. And it also having the same kind of numbers the person can able to read from the different distance. The main important thing is they can able to read from the 20-meter distance as it is same for the Slanel chart. But if the person having difficulty in doing that, you can able to reduce the distance. Instead of 20 meter, you can reduce to 10 meter. But the thing is, you have to be double the visual acuity. For an example, if he is having a 20 by 70 in 20 meter and you have difficulty in reading that, so you can able to decrease the distance to 10 meter, but we have to be double the visual acuity. That means he will have 20 by 140. So you can able to double because we are reducing the distance. So that is one of the facilities can available by using this Chronister packet acute chart. And another advantage of using this chart is you can able to carry this chart anywhere because it's a packet size. You can put in your core packet and you can take it whenever you want to measuring the visual acuity. You can able to use it. But the Finney-Blunt chart is like the big chart. Sometimes it will be difficult for you to carry, and you can use this Chronister packet acuity chart both for adult and also the children's. So the low vision acuity we see before is based on the distance one, but this MN read chart which will be measuring the near visual acuities, and it is also measuring the reading ability of the person. So one of the difference between the other chart and this MN read chart is, so it's not only asking the person to just to read the letter, it will ask the person to read the sentence or reading the paragraph. Because if you see in our daily day-to-day activities, just reading a letter is not be any more functional. Reading a statement or reading a paragraph is like think like a more functional. For example, if you want to read a newspaper, you should have some good reading ability task, then it will be easy for you. So for that purpose, this MN read chart has been mentioned, and in the practice guideline for an American Occupational Therapy Association, you can able to use this MN read chart in order to identifying the near visual acuity and also the reading ability of the person. And this is also having a normal from 20 by 20 up to the 20 by 400. You can able to see it here. And you can ask a person to read the sentence. If the person is having difficulty in reading the normal visual acuity, you can just gradually ask them to read the letter where they can able to see it very clearly and they can able to read. Suppose the person can able to read only this big letter, like my father take me to the school for every day in his big green car, then the patient has difficulty in this one. So you can able to mention his visual acuity is like a 20 by 400. And you can also use the timer when the person start to reading, so to check how speed he can able to read the particular sentences. So you can able to use this MN chart as a pre and post test after you giving the rehabilitation process to identify whether the reading abilities has been getting improved or not for the person. So this MN chart can be most widely used for an occupational therapist for the near vision acuity. So these are the different types of visual acuity charts. So next we have to deal about the refractions. So refraction is the image you're going to be see without any problems. So that means your refraction is normal, that we call it as an emmetropia. Emmetropia means a normal refraction. It doesn't have any kind of a problem in viewing the object. If you have any problem in this refraction, then we call it as a refractive error. So there are different types of refractive errors. We have myopia, hyperopia, and astigmatism. So myopia is called as near sightedness. So that means the person can able to see the near object, but they will have a difficulty in seeing the distant objects. So that's called as a myopia, nearsightedness. So what will happen here? The image, the focal point, which will be falling in front of the retina. So actually the focal point has to be fall on the retina, then the retina has been processed to the optic nerve. But here the image of the focal point of the image has been falling just in front of the retina. So the person cannot able to see the object which is on the distance. So when they bring the object very nearer, then they can able to see it. Next is the hyperopia, is like a farsightedness. Here the person can able to see the object in distances, but they cannot able to see the object in very near. They will have kind of an blurred visions, because you can see the focal point which is falling far behind the retina. So it will be go beyond the retina, so it will not able to catch the images clearly. So that called as a farsightedness or hyperopia. Astigmatism is like the focal point of the images which has been formed in the different areas. It's not only straighted on the retina, it may be fallen on the other aspect of retina. So the person cannot able to see the sharp images like one single point images. They can able to see the images like very big and blurred, and they cannot able to see the particular details of the images. So that's called as a astigmatism. That means they are having the irregular visions or blurred visions. So this is mainly happen because the eyeball is losing its shape, or the cornea will be lost its shapes. So the cornea cannot able to focus images. Do you remember I mentioned in the anatomy, the cornea is a structure which will be focusing the images. So because the shape of the cornea is getting changed, so cannot able to take the images appropriately and to give it to the retina. So this is called as astigmatism. And the next one is like presbyopia. Presbyopia is mainly happen due to the age-related factors, because when you're getting older, the flexibility of the lens has been getting affected. So, for example, if you want to see some object in a very short manner, you will be try to constricting your pupil and you can focusing on the object, or you want to concentrate more. So this kind of an accommodation changes are happening in the lens, but due to the age-related process, the lens will be affecting his flexibility. So what happen is like the images will be fall far behind the retina, so they cannot able to see the image correctly. And this can be usually corrected by using the glasses, which can be prescribed by the optometrist. And here I will giving you some of the informations about how to correct the hyperopia. Hyperopia, you know that the retinal images will be, the image will be falling behind the retina. So we need to be bring the images back into the retina. So usually we using the convex kind of a lens, because the convex kind of lens which will be giving more convergent factors. So it will bring the images back into the retina. And you can use the concave lens in order to correcting the factor of the nearsightedness, where the images will be falling in front of the retina. By using this kind of lenses, so we can able to bring the images go back to the retina by means of creating more divergent factors, and it will be goes back to the retina level. So this is the different types of refractive errors. So this is an epidemiological study which is done on the presbyopia, so due to the age factors. So this will be giving an incidence that more than 70%. I just concentrate on India. You can see that more than 70% of the population in India is having this presbyopia, and sometimes they will not having the awareness to correcting this kind of refractive errors. But if you see in other well-developed countries like US, Canada, and Australia, New Zealand, you can able to see they have only a less amount of the population having this one, because their vision already getting evaluated, and most of the population is getting corrected visions. So basically what we have to know is like there is a lack of awareness among the patients and also among the other professionals in order to creating the awareness to the people to get corrected their refractive error visions. So next is the visual field. So visual field is individual can see the visual world in a straight-headed point of fixations. And here we having the normal visual field. If you see in the more vertical aspect, in superiorly, you having 60 degree, inferiorly you have 75 degree. And for laterally is 100 and medially is like 60. So the total, the horizontal vision ability is like 160, and this the vertical vision ability is 135. So this is the normal visual field limits. If the person is having any field loss less than 20 degree, then they will need the visual rehabilitations. because it comes under the definition of blindness. If your visual field is 20 degree or less than 20 degree, then definitely you need visual rehabilitations. As in the OT part, we will be morely concerned on the two types of a visual field. One is peripheral visual field, and another is a central visual field. So we're going to see what is this peripheral visual field and central visual field. So you can see here the central visual field loss. So especially you will have difficulty in see the details of the images which has been presented in the center aspect, but you can able to see the images on the peripheral side, but you cannot able to see the images on the center part. So we call it as the scotoma, which will be affecting the central part of your vision. And this type of a visual field, the central visual field loss, mainly you can see in the age-related macular degenerations. So next is the peripheral visual loss, where you can able to see the central visual field, but your peripheral area will be getting affected. So this we call it as a tunnel vision. So you can able to see only the particular part of the images. So the peripheral area will be affected. This type of vision loss can be usually seen in conditions like glaucoma. And this type of peripheral visual loss will be leads to get a lot of motor vehicle accident, because sometimes the people will not notice this kind of an error. They will be doing their day-to-day life activities. Sometimes they will not able to see the full images of the road, so they can more related to get into the accident. So next is the visual field cut. So mainly caused due to any of the neurological damages like cerebrovascular accident or traumatic brain injury, or Parkinson or multiple sclerosis. So example what we have given here is a homonymous hemianopia. You can see the person cannot able to see the total left side of the vision. She can able to see only on the right side. So you will have a total left visual field has been cut. So these are the different types of visual field. And as an OT, we must be considered about the different types of visual field, how to correct these problems. So next is a contrast sensitivity. So this is one of the strong area where OT has to be concerned, because the contrast sensitivity will be strongly associated with the many of our daily life activities like reading performance, mobilities, driving, recognizing the face, especially for the communications, because you cannot able to identifying the emotional reactions which has been shown on the face if you don't have a good kind of vision or ability to distinguish the different parts of the faces, and also having difficulty in doing ideal activity. So that's why contrast sensitivity is very important to assess by an occupational therapist when you want to do any kind of environmental modifications or changes. We have to think about the contrast sensitivity. So the contrast sensitivity means the person can able to see an object even at the lower contrast. So for example, the normal person, even it is a low contrast, I can able to see the images. For example, you can see in the low contrast, I can even see some kind of small dotted structures, even the contrast is less. So it means that my contrast level is good. Maybe I can detect my contrast level is 25. If it is like 1 or 2, I cannot able to see it, but maybe 10 or 20, I can able to see the images. So it will be determining my contrast sensitivity. So the ability to see the lower level of contrast sensitivity, we call it as a contrast threshold. So how much of a lower contrast level you can able to see an object. So that is your contrast threshold. So it is important for us to assess the contrast threshold of the client. And based on that, you can able to do the modifications. So next, another term we have to be understand is about the contrast reserve. Here is a difference between the contrast of the object and also the client contrast threshold. For example, my contrast threshold is 50 and the object contrast is only 25, means that means I will have a difference of 25 contrast levels. So I cannot able to see the object is like a 40, 30 or 20. So if my contrast level is 50, definitely you have to do the modification of the environment, make the contrast level is more than 50 for the client. It should not be less than 50 for the client. If it is less than 50, then the person cannot able to get all the images in the environment. So that's why it is very important. We have to be understand about the contrast threshold and what is contrast reverse. And we have to check with our client when you're doing the modification for our persons. So if the contrast level of object is less, the person has to be increasing the contrast level. So we need to be increasing contrast sensitivity of the person. If the object contrast is more, then we no need to have increasing the contrast sensitivity, it will be decreased. So it is like inversely reversible to each others. So that's why contrast sensitivity is very, very important for occupational therapists to know about it. And here they're giving you some of the common objects which having the normal contrast. For example, if you have a maroon chair with a maroon carpet, so it is very difficult to differentiate. So you can see the contrast percentage is only 5. So it is very difficult for the person to differentiate the carpet and the maroon chair. The same thing, you can keep the maroon chair and the gray carpet. So it will have a good contrast. So you can see the level of contrast is like a 74. So patient not having any kind of a difficulty. So like that, we have a different object with a different contrast level. Maybe you can see the US currency, the contrast level is like 55 to 60. Maybe I think the Indian currency which we are using now, we're having a different colors of color, very, very high contrast color. So it will be easy for the low vision people to identify. We have a pink color, green color. So we have a different kind of colors. So easy for the low vision people to identify it. So next is light modulations. So our environment will be fully covered with the lights, and we need to see whether the patient's environment will have an appropriate light. If the person environment doesn't have an appropriate light, definitely it will be affecting their daily life activities. So it is mandatory for an occupational therapist to assess the light in the environment to check how much of a luminance has been presented in that particular working area. For example, taking a student who do some reading activities, whether in the particular space will have the appropriate light or not. Maybe you can using the lux meter in order to measuring the luminance level, and you can ask the person whether they have any difficulty in that particular space in the reading, or whether they will be satisfied with the light or not. So if the person is not satisfied, you can changing the watts of the bulb, and you can check with the person after changing the light whether they will have the satisfaction and the performance level is getting increased. So we can able to do some modifications and checking the pre and post level. So by means of this, you will helping the patient. So this is the light modulations. Sometimes when you're driving, you can able to see the glaring of the sunlight. If you are normal accommodation, then it's no problem. For people who having a low vision, which has been unnoticed, and they cannot able to tolerate this kind of glare and things, so they may get into an accident because they cannot able to control the glare. So if you want to control the glare, maybe you can go with optical devices like a UV light rays spectacle can able to use. And also we need to be correcting our working space environment with appropriate light level. So as an OT, the light modulation is also very important. So when you do the modification for the patient. So next we have to check whether a patient is having the binocularity. Binocularity means the ability of using the two eyes to focusing on the particular object. Sometimes the person is having difficulty in this kind of binocularity. So we have two different types of condition. One is amblyopia. Amblyopia, the person cannot able to having the clear visual acuity on the both eye. Maybe they will have the good visual acuity on one eye, and another eye they doesn't have the very clear visions. So sometimes we call this as a lazy eye. One eye is not very focusing on the particular object. So definitely this will be affecting the occupational performance of the patient, especially in reading, writing, or doing some kind of functional activities. So we need to be checked whether the patient is having any kind of an amblyopia or not. So next is the strabismus. So the strabismus, you can see inability to focusing on the object. So the eyes, both eyes will not be at the same places. So this is mainly due to the weakness of the eye muscles, the rectus muscles. So maybe leads to this problem. So either one eye will be in the up or down, or it may be inward or outward. Suppose if it is go like a more inwarded, we call it as like estrophia. If you're going more outward, we call it as extrophia. And it's going upward is called hypertrophia, and downward is like hypotrophia. So what will happen if the person is having this kind of strabismus? Because sometimes they will have like double visions. They cannot able to see the object very clearly. So they can have the double vision and the inability to carrying the detail, all the details of the objects. So that are the different concept of the visions. So we have to be understand about it, and when you are evaluating your patient, we have to be look all the vision concept. So common eye diseases which has been involved in the low visions. We have age-related macular degeneration, diabetic retinopathy, glaucoma, cataracts, which is most commonly seen nowadays, and retinitis pigmentosa, and the neurological diseases. So what is the age-related macular degenerations? So it will happen for the elderly populations. Mainly the problem which will becomes in this AMD is like a central vision loss. We already see the central visual field has been getting affected for the patient. So you can see the images here. The central visual field is getting affected, but the peripheral can be seen, but it's still like more blurry kind of visions. There are two different types of macular degeneration. One is dry, another one is a wet. So what will happen physiologically means the retinal pigment epithelium is getting affected due to the degeneration process. And you can see the most of the AMD will be start with the dry AMD, and then the progressive, the more damages happen to the retinal layer can be leads to the wet macular degenerations. So what is a dry macular degeneration means you can see a lot of debris. So the dust and dust material you can see, and sometimes there will be some scarring on the macular region can able to see. So it will be affecting the view of the central point of the eye. And the wet AMD is like they will have a cluster of the blood vessel which will under the macula. So you can able to see there is a lot of cluster of blood vessel has been there. So the focal point of the images cannot able to travel to the retina. So the patient cannot able to see the images, especially on the center point of the visions. So that is called as a age-related macular degeneration.
Excuse me, sir.
Yes.
Some people are not able to see the screen, the presenting screen. So is it possible for you to restart it, because someone else presented their screen? So I think some people lost it.
Okay, so I will be start again.
Yes, sir.
I stop sharing and then start sharing, right?
Yeah, from this slide onwards, sir.
Okay.
Sorry, sir.
No problem, no problem.
I request everyone not to press the present now button, please.
Is it visible now?
Yes, sir.
Is it
So
visible
1
to
minute,
all
let
the
me confirm. Is it visible for everyone? Please comment on the chat. Okay, sir. Yes, it is visible.
Okay. Thank you.
Thank you.
Okay, so we will continue. So we've seen about the AMD. Then next we're going to see about the diabetic retinopathy. So the name itself, you know, it has been caused due to the diabetes mellitus. So the diabetes will be affecting a lot of small blood vessels. It will be affecting overall the body parts. Eye is also getting affected because it's not only sparing eye, also the eye is now also affected. So the diabetic retinopathy, we're having a different visual problem, which can be ranging from the floaters to the total blindness. So you can see the images in the right side corner, on the top of the right side corner. You can see the images. You can see the images with a lot of floaters. Floater is nothing but sometime when you close and open your eyes, you can see like the worm-like structure which will be flowing in front of your eye. So that's called as a floater. So this type of a floater which will be affecting the images which can be falling on the retina. So you can see there is a small dot-like structures. You cannot able to see the images very clearly. So you'll have like a more blurred kind of visions. If it can be in the starting stages, but if the the disease is getting progress, then it may lead to get some kind of total blindness. So we can divide the diabetic retinopathy into two types. It's called as a non-proliferative and also the proliferative type. So in the non-proliferative type, it can be divided as a mild, moderate, and severe category. So initially, you can see in there will be a lot of small cotton wool spots, or they maybe have like a small hemorrhages are happening inside the eyes. So because of that, you can able to see the images like this. But in the proliferative diabetic neuropathy, it is like more advanced stage. If your diabetic is like a very version, so it will causes the more damages to the eye. So you can see the lot of neovascularization, which can be seen in the more proliferative stages. So you can see the macula, which has been totally getting affected, so the person cannot able to see the visions properly. So it is mandatory for the OT when you dealing with a patient with diabetics, in order to taking the medications and putting the insulin. You know the different types of diabetes, like insulin dependent and non-insulin dependent. So make sure they will be taking their medications properly, and also ask them to go for the repeated eye checkups to the optometrist or ophthalmologist in order to in line with the vision abilities. So it is one of the important role of an OT to educate the patients about whether they do the follow-up properly or not. So next is the glaucoma. So the pressure inside the eyes will be getting increased. So this will be causing the compression of the optic nerve. Sometimes if it is in a very severe conditions, the compression of the optic nerve will be causing more total blindness for the patients. So here what will be happening means they will have a lot of loss of peripheral visions. So you can see they will have a lot of the peripheral visions field has been getting affected. Only they can able to see the central visual point. So this glaucoma can be able to treat with a lot of eye drops or with a surgery. So it can be treatable. So if the person has been having this kind of pressure, usually they will check the pressure when you go for a regular eye checkup. So they will be checking the pressure of the eyes also. And it must be treated before it damaging the optic nerve. So if the optic nerve is getting damaged and it is difficult to recovering back in the information goes to the optic nerve, because it will fall under the interior aspect of the eye and difficult to cause treating the problems. Next is a cataract. So it is a very common condition we can see nowadays. So many people are visiting the eye hospital mainly because of this cataract problems. So cataract is nothing but there is a clouding of the crystalline lens which has been present in our eyes. So this cataract surgery is most common. If it is left untreated, so it will be causing some dull color or blur visions. So the client who having the cataract, so basically they will have a decreased contrast sensitivity. They have difficulty in identifying the difference in the contrast of the color, and they may also more prone to getting the motor vehicle accidents. So that is very important. So, and one of the thing here is the person who developing the cataracts cannot able to see the problem initial. So this cataract is not comes in a 1 or 2 day. It will be like a slow progressing conditions. So it will take some time. So the cataract can be started slowly, and then it will be covering the whole lens, or maybe it's covering the part of the lens. Then only covering the part of the lens, half part of the lens, then the person can able to see the difficulty in seeing the environment, and they will be go for consulting the ophthalmologist. So next is the retinitis pigmentosa. It is a progressive hereditary eye diseases which are also causing some damages to the retinal cell. So mainly you can see people will be start noticing the problem only when they having the night blindness. So it will not seen before. Only they start facing the night blindness and they start losing the peripheral vision, then they can go for the consultation with the doctors, and it is like more progressive in nature. So initially they will having a central vision is spared, so they will have the peripheral visual loss. The central vision will be there, but when the condition is getting more progressive, so the central vision is also getting more shrink, and they can just see only like a pinhole size of the images. And this retinitis pigmentosa may even cause some total blindness for the patients. So neurological diagnosis, mainly the optic nerve is getting damages, so you will having a visual field loss. So some conditions like glaucoma, stroke, or multiple sclerosis. So another important thing we have to be know about the physics of the optics of the lenses, because when the optometrist is suggesting the low vision devices for our patients, and we have to be evaluate the devices whether it will be useful for the patients in doing all the daily function activities. And if you find there is any difficulty for the patient in using this kind of an optical devices, you can also recommend the patient to go for a selection of the different devices, or you can go for suggesting the ophthalmologist or optometrist to talk about the client problem, how he facing the problem in using the devices, and you can suggest them good optical devices which can be used in various daily life activities. So optical device is very important role in the low vision rehabilitation. So as an OT, we have to be know about the different optical devices and its functions, how it can able to work, and we have a great role in teaching how to use these optical devices in the daily activities. So further, we need to know about the physics of the lens. So you can see the convex lens, which will be more focusing about the convergent activities, and concave lens, which can be more go for the property of a divergent property. So if the person is having a far-sightedness problem, you can usually give the convex lens to bring the convergence, and those who are having nearsightedness will be go for the divergent to bring the images back into the retina. There are different types of lens. And convex lens we always call as a plus lens, and the concave lens we call it as a minus lens. Maybe when the optometrist is suggesting the glass or the lens for you, you can see the sign, they will put the plus signs, so it means that they will be providing the convex lens, and if they're putting a minus signs, it will be providing the concave lens. So mainly they will use it for far-sightedness, and concave is mainly for the near-sightedness. And they will have a cylindrical lens which can be given for the astigmatism, people who are having the blurred kind of visions. Another terminologies which can be used in optics, like accommodations. Accommodation means any of the refractive error corrected by the eyeglasses, that means called as an accommodations. And you should be know how they were calculating the power of the lens. Usually they will be measure the lens power by means of a diopter, and this is the formula for checking the power of lens. And next very important thing the OT has to be understand is about the focal distance, or you call it as a focal length. This is the distance the lens to bring some parallel rays to for the sharp focus. So maybe what may be the appropriate distance level the person can able to see the images in a more clear way. So that is called as a focal length. So usually this is the formula to measuring the focal length. So how much of a diopter you are using, for example, if you are using 1, 2, 3, or 4, so according to that your focal distance will be getting changed. It is very critical for occupational therapists to design the distance of holding the optical devices during activities like reading and writing tasks. So next is the magnification. You will use a lot of a magnifier. So the characters of magnifier can be mentioned in the devices like 5x or 10x. So it will be mentioning that how much of a magnification can able to done with that particular kind of devices. And another important thing we have to be know is like a method of magnifications. We can divide the method of magnification is like a relative size magnifications. It is mean that you are not doing any changes in the eye of the person, or you are not giving any kind of lens changes in the eyes. We can just changing the size of the object. Instead, for example, if it is a small letter for the person difficult to read, you can just increasing the size of the letter. So we're just making a size will be bigger, so the person will not having any problem. So that is called as the size magnifications. So next one is like relative distance magnifications. Patient is not able to read the small letter. So instead of changing the size, you can able to bring the object very nearer to the person. So when you bring the object very nearer to the person, automatically they will having the magnification. So that is called as a distance magnification. And this distance magnification is can mainly done by the lenses magnifier, what we've seen before. You can use the different kinds of magnifier. You can able to adapt this one. So that means you will be stationary and the object will be moving closer to you, or the object will be stationary and you will be moving closer to the object. So next, magnification is by means of projections. You can using a lot of electronic devices like CCTV, or you can having a lot of OHP devices you can able to use to magnifying. Nowadays we have a lot of iPad or iPhone will have all this electronic devices will have the magnification. If you're not able to read it clearly, you can able to expanding the size of the images. So next we have to understand more about the field of view. So the size of the area which can be viewed through the lens. For example, if you are using a big magnifier, so your field of view will be bigger. And if you are using a small magnifier, then you can see the area of your viewing the particular object, which will be very smaller. So it will be depend upon what type of a lens and what type of a magnifier or telescope you can able to use it in order to see the field of view. If you are using a telescope, your field of view will be very less. If you are using the magnifier, your field of view will be getting increased. And the lens, if you're having a very weaker lens, so weaker lens will be increasing the field of view. And if you're having very stronger lens, the field of view will be getting reduced. So this will be like going oppositely. So if your patient is having a bigger field of view, and you can suggest them to go for the weaker lens, or they just need only the sharper view, then you can go for the stronger lens. So we need to be understand the property of this optics, and we can able to suggest the devices appropriately for our patients. So we'll see a lot of basic informations related to the eye and also the optics. Next, we move on to how we can able to apply these models into our practice. So this is an ICF model. So how we can able to implement it for visual impairment. So the health condition is eye diseases. Because of the eye diseases, you can see the body function and structure will be affecting. It will cause us some visual functioning problem. Because of that, you will have the limitation in activities, and the limitation in activity leads to participation restrictions. So the limitation in activity is not only because of the eye diseases, sometimes the environmental factors which will also causing a combined effect. For example, if you take the environment will have a lot of barriers for the person, and this barrier will be adding on for the limitations apart from the structural deficit in the eye. So we need to be considered about the environmental factor also, and some of the personal factor will also having an effect on the persons. So these are the low vision rehabilitation team members. So that on the top we will have the physician who having ophthalmologist or optometrist, and we have occupational therapist, and because occupational therapist will be dealing more about the environmental modification and daily life activities treatment, so that's why it comes under the second. And physical therapist can also help the person with low vision in order to improving the physical ability of the person. For example, the person having a weak muscles, having difficulty in holding the magnifier, so they can work on improving the muscle power to sustaining the endurance level of the patient in holding the devices when do the aerial activities. And the psychiatrists and psychologists also having a greater role, because when you're having a normal vision, you don't have any problem. Suddenly your vision is lost, so you will be enter into the psychological issues, like you will get more depressed, and your self-esteem and self-confidence will be getting affected. So during that time, your mental health ability is getting affected. So the psychologist can able to help you to give more counseling to overcome of your psychosocial issues. And sometimes the nurse who are having a specified certification in the diabetic, they can also suggest some kind of an suggestion for the optic devices. So vocational rehabilitation teacher and occupational therapist can be work together in order to bringing the optimum level for the functional ability of the person. And next is the orientation and mobility specialist. Because of the low vision, the orientation to the environment and your mobility pattern is going to be changed, because you're going to be walk with the canes, and your mobility has to be changed. So this type of a specialist will be giving the training for the person. And there may be a difficulty whether we having the specialist, especially in India, I don't know, we having the specialist on this mobility and orientation, because most of the time mobility will be targeted about the physical therapist, and functional mobility will be targeting about the occupational therapist. We will be working on that one. Next is the social worker will have a tremendous role in order to bringing about the different kinds of resources which can be helping for the people who having the visual problems. And next is the adaptive technology specialist, has been working along with the occupational therapist, because occupational therapists will be working more on the assistive technology devices. So we can work together in order to bring the appropriate technological devices which can be able to help for the patients. So all this one, we're not having like a separate role. So we must having some kind of an multidisciplinary approaches in order to dealing about the patient's problems. So that may be sometimes difficult. So I just read one articles which has been published in Indian Journal of an Occupation Therapist. Sometimes they will having a difficulty in sharing the informations or sharing knowledges with the different professional. So nowadays we will be more concentrating about the interprofessional education is very important, and it will be help for the patients to get some good improvement. So lot of multidisciplinary and interdisciplinary approaches can be applied when you facilitating the rehabilitation process. This is mainly for bringing the outcome of the patients. So as an occupation therapist, we have to be work according with our practice framework. And whatever the conditions you are dealing, you have to be work along with your occupation therapist practice framework. It may be a neurological problem, or it may be a musculoskeletal problem, or it may be a cognitive or mental related health problems, or visual rehabilitation is also fall under this one, because this is our framework and we have to be work along with that one. So for that, we have to be understand about our framework. So basically, it's a very big topic, but I cannot able to cover it, all the informations about OTPF here. But I just try to introduce something like the divisions in OTPF. We have a domains and the process. Domain is the area where we have to be working on our patient, and the process is the way how we are going to be dealing with our patient. So if you see the domains, there are many main important 5 domains are there. In that, the occupation, which is going to be the core area for an occupation therapist, where we can going to be deal more about activities of daily living, instrumental activities, and work, play, and leisure, and social participation is having the main important role. Apart from that, we have other domains like client factor, performance skills, performance pattern, and we can also see the context, which having a very good important role. So any one of the domain is getting affected, it will having the effect in all this one. For example, body structure, eye is getting affected, definitely the person will having a problem with performance pattern and also in the occupations. And the environment will be just adding the consecutive problems related to the client factors. That's why you can see here all the domains which having some dynamic kind of an interrelationship in order to bringing the occupational performance level of the patients. So we need to be understand about how we are dealing with these domains. So this is just an example how the visual impairment will be fitting according to our domains. So in client factor, especially we're seeing more about body structure and body function. So body structure, eye will getting affected, and body function, the vision impairment will be getting affected. So because of this thing, our performance skill like reading skill and writing skill will be affected. Sometimes the performance level and the demands of doing that particular activity will be getting increased due to the visual impairment. When you are normal vision, you don't have any problem in reading and writing. When you enter into the low vision, so it will be affecting your reading and writing. So the demands, which will be like physical demands or social demands or environmental demands, space demands, you need like more lighting, and you need to be changing a lot of things in the environment. So it will be affecting the performance skill of the patient. And your habits, next is the performance pattern, especially your roles and habits also getting affected. So as a role as a student will be getting affected because of your poor reading and writing skill, or your work will be getting affected because of your low visions. And sometimes your habits will also be changing due to the visual impairment. Before normal vision, you can walk normally without any of assistive devices. But after the low vision, you have to be use canes or you can use any of the assistive devices, and it will become an habit for you. So totally your roles and habits also be getting changed when you enter into the visual impairment. So next is the occupation. Occupation will having a lot of challenges to participate in the ADL and IADL activities due to the visual impairment. And you will also enter into the psychological problem. So the psychological problem will be getting affect the sleep. When you are in depressed, and the depression will be affecting the sleep, so the sleep will be affecting your day-to-day daily activities. So it all will be interconnected, and environmental domainal will be adding additional challenges to the person with visual impairment to participate and engaging in the particular environment due to the visual problems. So if you understand how to implement the problem into our domains, and it is easy for you to do the analysis of all these domains, and you can able to identify the problem, and easy for you to setting the goals. So how you can able to rationalize the OT can able to work in the low vision rehabilitation, because OT will have a lot of role in the geriatric population or elderly populations. So when you are concerning with the elderly population, especially you're talking about the dementia, or you can talking about the balance problems and the falls problems, all this problem has been interrelated with the low vision, because low vision is one of the age related factors. So when we are working in a geriatric population, so the low vision is also having the role in that one. So it may be a rationale for why OT has to be involved in the low vision rehabilitations. And OT will be working in the lot of chronic conditions like diabetic. We're also having a role in that one. So a lot of chronic condition will be affecting the vision. So OT can able to participate in that one. And the availability of an OT services are wide compared to the rehabilitation services. So according to the National Eye Institute, and also the National Institute in India, they will be suggesting that there is a lack of visual rehabilitation services which can able to reach the people who having visual problems. So OTs can be widely available. So we can able to use the OT services in order to delivering the low vision rehabilitation. And we also having a lot of role in related to the environmental modification, home modifications, and we have to be concerning about the independence in doing aerial activities. So we have a huge amount of a role. So that's why mainly I try to take this topic, because sometimes the scope of this low vision rehabilitation has not been fully aware about from the different rehabilitation professionals. So it can be an eye-opening session for them to include occupational therapy services into the low vision rehabilitations. So some of the common concern we have to be take when you are dealing with the low vision client is just like a general informations. So it's like just like a manners when you are dealing with the patient. So you have to be announce yourself when you are entering or leaving the room, because otherwise patient may get frightened if you suddenly go without announcing your name or who you are. So they will get frightened, and sometimes it will cause some psychological problem for the patient. So try to announce yourself before you enter or leaving the room, and try to give some conversation to the person before you start in an activities or ending an activities. And always speak directly to the person in a normal tone of voice, and try to call the person by the name or touch him or lightly on the arm. So before touch him, you have to be ask for the permissions. So request for the permission before you touch, and try to explain what you're going to do before you start your activities. Avoid giving some expression like it is over there or over here or right there or right here, because it will not give any meaning. So we have to give the appropriate direction instruction. Suppose you want to ask them to take a cup of coffee, you can just mention that the coffee has been just presented in your left side or presented on your right side. So you can just specify the direction, so it is easy for them to concentrating on that one. For example, if you're giving a plate of food, and you can able to demonstrate in the direction of the clocks. Okay, I will keep the potato on the 12 o'clock, and I will keep the rice is on the 3 o'clock, and I will keep the curry is on the 6 o'clock. So we can able to give the direction, so the person can able to imagine where the object has been available. So it is very important to mentioning the specific direction before you giving the instructions. Suppose if you're having doubt how you can going to help your patient, you can just ask the client, because the OT will be more concerning about the client-centered practice. So you can ask the client how you can able to help them, and you can be act according to that one. So it will be very easy for the person to following you. And do not rearrange the space of the person with the visual impairment, because sometimes they will have some memory of the object which has been presented. For example, the telephone. If I walk from my bed at 10 feet from my bed, I can able to reach the telephone. Suppose if you're replacing the telephone without informing them, they will walk 10 feet and they cannot able to find the telephone. So it should be very important. Before rearranging the space, you can be informing the person, or please don't rearrange the space, because they will have some specific type of a memory related to the object which was presented in the environment. And try to avoid any kind of an safety hazards, and try to keep the door always open or always closed. If it is in the staircases, please close the door always, and push the chairs which is in the up in different places, push the chair inside it. So this is a common concern when you have to be deal with the patients. So we see the domains already. Next, we're going to do the evaluation. So when you do the evaluation, you have to follow the OTPF evaluation process. So it will having three types of a process. One is related to the occupational profile and analysis of occupational performance. And next, we have to be deal about the intervention plan, implementation, and review the intervention. And finally, we have to see about the outcomes measures. So we have to have the collaborations. This is very, very important. So your therapeutic relationship has to be maintained very good between the client and also the practitioner. So the therapeutic relationship is very important, because the patient has to be believe that that you can able to help him in doing certain kind of a task. So once they believe that, it will be make them to get more motivated in doing the particular activities. So we're going to see the process, how to getting an occupation profile and analyzing occupation performance related to the low vision impairment. So these are the assessment which can be done related to the optometric, and most of the optometrists and ophthalmologists will be able to do, or the opticians can able to do all this kind of testing which can be seen before, and you can able to get the report from the optometrist related to all this informations. It is easy for you to get to communicate with the optometrist or ophthalmologist or opticians to get this information and try to implement that into your treatment practice. And if you're having a difficulty in getting information, and we are having a special assessment to checking the visual screening, we can able to see it here. So after the optical evaluation has been done, our OT evaluation has been started. So our main aim is mainly to determine what is the client's needs and wants, because we are the client-centered practice, and we have to be more focused about what is the client's needs. And we have to identify the factors that will act as a barrier for the development of the treatment plan, and the specific needs has been need. And we have to be interact with the low vision optometrist about the client physical capability and the living environment, because the devices going to be suggested only by means of optometrist. So we have to be give the clear information about the client capabilities, either is physical, cognitive, and other aspects, psychosocial aspect. All this one we have to be discussed with the optometrist, and their living conditions, so they can able to suggest appropriate low vision devices for the patient. And after you get the low vision devices, you can able to train the person how to use these low vision devices. So most of the time, people are going for the optometrist and they will get their glasses, but sometime after they get the glasses, they will not using it properly in the day-to-day daily activities. So it is mandatory. They have to be use it on the daily day-to-day activities, but sometimes they have difficult to how to use these optical devices. So in that case, what you can able to teach them how to use the optical devices for the day-to-day daily activities. So we have to be, before you evaluate, you have to be know about the functional abilities, what may be their current goal, and how is their participation in all the ADL, leisure, and work activities. So when you do the evaluation, you please try to concern about the environment. So this is very, very important, because most of the time we are not concerning about the context when you're giving the treatment for the patient. So we have to be very careful when you're giving the treatment. Please think about the context in all the aspect: physical context, social context, cultural context, personal and virtual context. So nowadays, due to COVID-19, we will be more related to the virtual context, because I'm conducting this session is also on the virtual context. So they need to know how to manipulating the technological devices if they're having it. And we have to be concerned about the cognitive and physical factors, because this is our day-to-day daily routine activity for an occupational therapist. And sometimes the cognition will also causing the problem. If you take the person with the dementia along with the low vision problems, when you're giving some kind of teaching strategies for this kind of a dementia patient, we need to be think about the cognitive level, and we have to be give the instruction according to the cognitive level. And we also think whether the condition is progressive conditions or not. So according to that also we have to be set our evaluation process. And we have to be see how these optical devices has been used in the occupational performance. If you find the optical devices is not suitable for the occupational performance, and you can able to recommend the new devices to the optometrist and ask them to providing the new devices. So how you're going to get the occupation profile? So by means of doing the interview method. So these are the information you need to be collect from the patient. So what is the reason for they seeking these services, and how you can able to engaging in the daily day-to-day activities, whether the day-to-day activities is successful or not, what are the barriers are they facing in the occupations, what is their interest and value, because based on their interest you can able to formulating your therapeutic activities, and checking the occupational history, performance pattern, and try to check about the environmental barriers, and checking the client priorities to desire target outcomes. So by means of an interview, you can ask these questions. And if you're having any specific related information related to the low vision function, so this is the questionnaire you can able to use to collect the information related to the occupational profile. So it is a veterans affair of low vision visual functioning questionnaire, because this has been come from the military, because low vision has been first started in the military aspect. So the questionnaire has been come from there. That's why they mention is veteran affairs low vision visual function questionnaire. So it is having 48 questionnaire related to the low function of the patient in related to the occupational performance. And these are all the other standardized assessments you can able to use to getting the information about the occupational performance. Most of you will be very known about this one, Canadian Occupational Performance Measure, where you can able to identify the client priority in day-to-day life activities, and also their performance and the certifications level. So next, you can also use a revised self-report assessment for the visual functional performance, or you can use the functional visual screening. So this is what I mentioned before. If you have difficulty in getting the information about visual acuity and visual field problems, you can use this functional vision screening. Is mainly used for the brain injury visual assessment battery, but you can take some of the component informations which can be assessed from there. So the guideline practice of an American Occupational Therapy Association has been suggesting to use COPM and also the BI-VIPA as one of the screening tool for the occupational performance evaluations. Or you can able to use the National Eye Institute Vision visual screening questionnaire for checking the visual ability of the person. Or you can use activity inventory and self-reported falls to getting the history of the falls, how many times they get falls. Based on that, you can able to identifying the barriers, and you can start to removing the barriers. And we have some independent measure, same like an functional independent measure. We have an independent measure, especially for low vision. It's called as a low vision independent measure. And you can able to find the difficulty in the functional activities of daily living, mainly related to the vision. For example, in kitchen area, what may be the independency getting affected in the kitchen area due to the low vision. So you can ask some questionnaire related to that one. And it has been developed by Smith in 2019. And we are using the geriatric depression scale, because you know the people low vision will go for psychosocial issues. So you can able to measure the depression scales. And you can also do the assessment of the lighting. As I mentioned before, in the light modification, you have to assess the environment of the lighting. So for that, we can use this assessment, home environment lighting assessment for HELA. So HELA is mainly assessing about the pre-intervention and post-intervention. That means pre-intervention means how the environment lighting before you do any kind of a modification. After you do the modification, how the patient is able to feel the performance and satisfaction level. So this can also be very important information related to low vision. And for home environment, you can also use eye hope assessment, because eye hope assessment is mainly to assessing the home environment for the people who having low visions, and also with the geriatric populations. And MN read chart, I already mentioned you, it's very helpful for do the reading assessment, the speed of reading ability of the person. So you can able to check with the pre and post assessment. And next is the interview and general observation. So this is always very common. As an occupational therapist, you should have a very good clinical observation skills. By means of having the clinical observation, you can able to detect a lot of problems which can be not identified by some of the standardized measurement. After you identify the issue by your clinical observation, and you can able to apply it in your standardized measure. So general interview and general clinical observation is very much important in order to identifying the ADL and IIDL problems. So these are all the few standardized assessments. So we can able to use it for the low vision rehabilitation in related to the OT perspectives. So next is the intervention process. So we have to start with intervention plan, writing the goals of our patients. After you writing the goal and selecting the appropriate treatment methods, and you can start implementing the intervention. And after you give the intervention for a few weeks or few months, and you can able to check the review of the intervention, whether you will get the appropriate improvement or not. If you're not able to get the improvement, and you start to review your goals, and then planning your interventions, and then start to give the new treatment intervention for the patients. And finally, you have to be achieving the outcomes. So how I'm going to be practicing this low vision rehabilitation? So according to the practice guideline given by the American Occupational Therapists Association, so they basically mention about the multi-component approaches is very, very important, and it will give a lot of improvement for the patients. So as they mentioned the practice guideline, so it is mandatory for us to follow the practice guideline. As usual, it is in America, but not in India. But anyhow, we have to be follow what has been practiced in a well-known area. And you know, most of the time we are following a lot of guidelines which has been produced from the American Occupational Therapy Association. Maybe we can modify according to the Indian practice guidelines after we reviewing the interventional process for our patients. So they believe that a multi-component approaches is the best approaches, and it will be including the following 6 categories. First one is about the education of the eye condition to the patients or the client. And then we have to be providing the resources advocacy. So what are the availability, where the treatment area, where the treatment availabilities are there, or what may be the reimbursement process where you can able to get the money for buying the assistive devices, or where you can go into reimbursement for do the home modification or environmental modifications. So this kind of resources can able to give by the advocacy. You know, one of the role of OT is just giving the self-advocacy. So it is one of the treatment approaches. And next is training in the problem-solving strategies. So this has been included, like whenever you do the treatment implementation and you find the patient is facing any problem in doing an activity, so we need to use some strategy there itself and try to solving the problem. So you have to give this problem-solving strategy until you find the patient does not have any problem in doing the task. So next is the environmental modification and eccentric weaving, and the training in using the optical and non-optical devices, and instruction in doing the adaptive strategies. So how you can able to modify the way of doing the activities in order to facilitate the daily performance activities. So in this, the first 3 categories is mainly about the educations and giving the informations and try to solving the problem when they're doing activities. And the other 3 will is like environmental modification, what we are going to be seeing today, and what are the different things we can able to do. So the first thing in the environmental modification, as we mentioned before, we have to do the changes in the lighting, and sometimes the low vision will causing the glare problem. So we need to do the modification to avoid the glares. So how I can able to increase the lighting? By just increasing the watts of the bulb to the maximum allowed level of the fixtures. Maybe in a one room environment, they will be allowed to do only like one fixtures, or maybe you can fixture is like the light which has been presented in the room. For example, if you have a small area of room and you have only one light, and that light will not be sufficient, maybe you can increasing the wattage of the lights, so the area will be getting bigger and it will be easy for the person to see the images in the environment. And task lighting is very important. When you're doing like reading or writing activity, you can use this gooseneck lamp with a solid shade. It can be very good for increasing the lighting aspect. And placement of the light is also very important, where we have to be place the light. So when you're writing, try to put the light should be opposite of your writing hand, so it will not be producing the shadows or gallops which will be comes from the light, which will be affecting the field of view. And try to use halogen kind of bulbs, because it will be having a very less glare. And you can also use LED lights. LED lights will be giving more brightness for the patient to able to see the object clearly. And always try to check the light should not able to cause glare. If you're having a glare, try to use some of the adaptive devices to reducing the glare, like a visor. You can put the visor or you can put the hat in order to avoiding the glare. And try to maintain the different types of lighting, and try to check which lighting will be very much useful for the patient, and try to put the particular light for the patients. So we need to do the HELA assessment, try to identify the lighting issues and try to solve the problems. So these are the different lighting options. I mentioned the goosebumps, and you can create a more extra light in the cardboard in order to easily visible the object and the colors. Or you can use the base light in the kitchen in order to identifying the objects. And if a patient is having a problem in reading and a glare when they're reading, you can use this kind of a typoscope. Just they can able to see only the area which one they want to read, so it will be avoiding the glaring. Or we can able to give a lot of adaptive devices for writing. You can use this kind of things for writing, or you can use this to signing the signature of the check. So you can have the typoscope only for the signature of the check, so the patient can able to sign the check in the appropriate place, so they cannot able to misplace it. And you can use this kind of an yellow fixtures if you're having any kind of a glare while you are driving or doing any activities. So you can use this one. It will be avoiding the glare, and it's also magnifying and increasing the field of view for the patients. So these are the few example for the lighting options. Next is the important is the contrast modifications. So this is the example for the few contrast modification you can see in the picture. So here you can see the difference between the toilet seat in white color and the toilet seat was in a blue color. So they will have a different contrastivity. So it is easy for the person to see the environment. And also you can see the wall with the light color and the bright color. So this is the bathing area, and the light color is where the towel has been presented. You can see light wall with a dark green towel. So the patient can able to differentiate between the wall and the towel. So they can able to easily identify it. And some of the, so you can see in this picture, there is no light and there is no indications of the contrast mark in the staircases. So this maybe leads to get falls for the elderly population. Most of the elderly populations will be fall in the staircases. So here you can do the modifications like increasing the light, and also you can increasing the edges with the bright coloration strips, so the low vision people can able to easily see it. And you can also color the rails with the bright color, so they can able to identify the rails, and it will be increasing the safety process for the patients. So that's the few examples for how you can do the modification in the contrast levels. So it's an example for the good contrast, and this is the example for the bad contrast. White colored cloth with a white plate, difficult for the person to distinguish it, but you can put the black color mat with the white color plate, so the person can able to easily distinguish the sensitive contrast sensitivities. And here I'm going to show you the small video related to the different adaptive tools which can be really used by the person who having a low vision impairment.
I'm Nanette, and my condition is called sarcoidosis uveitis, and at the moment my vision is quite poor. My landlord has installed highlighted steps, and I've got a rail that takes me along this now. I have in the past had vision aids from the vision clinic, but I find as my vision is getting worse, I have to sort of upgrade what I'm going to be using to read. Now I find that a lot of companies, especially utilities and banks, will provide you with all of this marks that they will provide you. When I get my bill, I normally pop in a CT. And this is the first optical lens I like to see. You put it on the letter or whatever you want to do, and you run it, literally move it along the line of text. It's very basic. With the video magnifier, I'm able to look at pictures of my children. It's incredibly easy to use. The buttons are high vis. You adjust the color if you need to adjust the color. You adjust the magnification if you need to. The one that I purchased has a camera as well. So when I'm shopping, which is what I use, I can actually use it to magnify the ingredients of a product I'm buying or even the price. This is a liquid level indicator. It's got 3 prongs at the back, and all you do is pop the prongs into the cup and hang it from the cup. Liquid level indicator works by telling you whether the water has hit the mouth. Before I sort of got organised and had dishes with colours, I would inevitably dish up things onto the table, not into the plate or the bowl. And now that I've got dishes that have colours, I know what I'm doing without the colours. I would frequently be stabbing things that I didn't do with, or trying to do things that weren't there or in the wrong place. And when I go to the action resource center at RIYADH, it's like a kid in a candy store. They encourage you to really think, don't buy something just for the sake of buying it. What use it has to be used on a regular basis, and they help you a lot in that way. For more information on the signpost, visit riyadh.org.uk and search for everything. My name is Byron Clearness. My condition is local. My sight is very, very poor. There is no sight in my left eye. I'm about 8%. When I first moved in apartments, the lights were very, very poor. I decided it's going to be I've been alright. That was 5 years, 3 years. I've got gadgets, many gadgets around the house. But the key, like my shirts, and I do like to be color coordinated. But the difference is a little gadget you hold in your hands, like an watch, and it's something that's a little personal. Talking gadgets are really similar to the Talking scale is similar to the color detector. You just switch it on. Just put measuring notes, metric times with the other one we call old school measuring power analysis. As long as you put your empty word it's experience your also take care of them, and they will be prepared. For more information on his visit RNA.org.uk and search for rehabilitation.
Okay, so the video will be giving you some of the information and a few adaptive and assistive tools they can be able to use, and some of the talking devices is also very much helpful for the person in doing their daily day-to-day activities. So next is the visual field enhancement, how I can able to improving the visual field for the person who having a loss of a visual field. First one you can see in the right corner of the picture. So you can able to use the prism lens, or this prism will be very good in carrying the informations from the loss of a visual field and bring it to the normal visual field area. So especially we can able to use this in the stroke patients who having the loss of visual field, unable to see the object in the neglected area, and try to bring the object towards the normal vision site. And next is eccentric training, and OT will be having training given to the person in ability to reading and materials. So this eccentric training is first mainly people who are having a central vision loss. So people who are having a macular degeneration, central vision loss, you can help them to use this eccentric training for reading purpose. So first we have to ask the person to fix the center area, and then ask them to see which area they can able to clearly see the images, and then try to do the adaptations, make them to read on the particular area. So after that we are going to show some video related to how to facilitating the eccentric training. And next is the canes. Mainly the canes, they can use it for walking and also for the indications for the others. Maybe in the previous video you can see how they will be using the cones. You have to use the cane by moving to right and left in front of you, mainly to identify if you're having any obstacle or barriers in front of you when you're walking. And this will be a great indication for finding the barriers. And another, that's called as a guide cane. And support cane is like not used for walking, but it will be help you to notify others when you are crossing the roads and something like that. So we can able to notify that you are visually impaired. So it's a notification, so others will know and it will be able to help you. And next, you can able to teach the patient by do the trialing techniques. Trialing technique is like as a person to touch the wall when they're walking, as a person to touch the wall with the hand, and then when they're walking, they're just going along with the tracing the wall, and they can able to easily identify if they're having any barriers when they are walking. Either they can use the hand for tracing on the wall on the upper level. They can also use the cane for using identifying the barrier in the lower level. So as a person to memorize the barriers they are facing whenever they do this kind of trailing techniques. Next is the guiding techniques, and the guiding techniques, one of the guiding technique is using the dog. So the dog will be as a guide for the visual impaired person, try to identifying the obstacle barriers. Once you are very much aware about your pathway where you want to go, and you can able to use this dog as a guide. Please don't touch the dog until you are getting a permission from the person. So it may be disturbing them in identifying the space. And another guiding technique is like if you want the person to walking along with you, you can make the person to holding your elbow and make the person 1 inch behind you, and when you're going forward, make the person to be coming along with you. So this can be one of the great guiding technique for the person helping with the visual impairment. Before you help them, you try to ask them, because many of the visual impaired person doesn't need any kind of a guiding technique, because they will be mostly independent in doing the task. So if they really need an support, then you can able to give them the support. And you can also give the guiding techniques in the seating aspect, how to make the person to sit down and stand up. So you can able to guide them by your expertise, and it will help them. So if you want to know more about the guiding techniques, you can just do the YouTube. You can find a lot of videos are available for teaching the different guiding technique for the people with the low visions. So this is a way to we can enhancing the visual field. So here's the video how to give the eccentric training for the patient.
There's also a form of training which can help people with vascular disease get better use of their remaining peripheral vision. It's called eccentric viewing because it doesn't rely on the central vision. American societies volunteers run training sessions and so do some other organizations. The training helps people to identify the part of their retina which is working best, and then helps them to change the way they look and read to bring that part of the retina into the center of their vision. It doesn't work for everyone, but it's very valuable to those who can master the technique.
So that's a video showing about how you can help the person who having macular degenerations in order to helping them to the reading abilities. So next is optical devices. We call it as magnifiers. We have different types of magnifiers which can help the person. So the first one is a spectacle magnifier and handheld magnifier. We have two types. One is illuminated and another is non-illuminated. That is like one is illuminated means with light and non-illuminated is without light. And also we have the stand magnifier, and the stand magnifier which can kept along with the spectacles. And we have a bar magnifier, telescopic magnifier, and electronic magnifiers. So spectacle magnifier having different types. We have off-high spectacles, TV glasses, sporting spectacles, and loafers. So loafers is like an extra attachment can be given along with the regular glasses. And this will be allow you to having a hand-free magnification because you're going to be put it on the eye and there is no use of a hand. So your hands will be free. And you can able to use this for the close activities, especially the half-eye spectacle and the loopers can either mainly used for identifying the close near visions, or sometimes you can able to use it for the distance also. So one of the advantages is hand using free, and one of the disadvantages like half-eye spectacle can only to use the close viewing distance, cannot able to see it for the far viewing. So you can see the different types of spectacle magnifier, and this is a kind of a loopers which will be more focusing more about your closer viewing. So suppose you're not able to see the object very clearly. So next is a handheld magnifier. So the size will be vary from 2 times of magnification up to 14 times of magnifications. Maybe you can see the magnifying the size of the lens is going to be become smaller. For example, here we have the big magnifier. So the lens will be very weak. So it will be like 14 or 15 times. So the lens will be very weak, where you can able to see the a bigger field of view, but the letters will be like not very sharp. But when you go for the stronger lenses, you can see the size of the magnifier is getting reduced. So this is a weak lens, and this will be the stronger lens. The stronger lens will having the smaller one, where you can able to see the images exactly very clear, but your field of view will be getting reduced. But here your field of view will be good, but it will not like a more sharp images, you cannot able to see it. And in order to bring back the sharp images, you need to be hold the magnifier at the particular distance. What I mentioned before is the focal length. The focal length has to be maintained. So the OT has to be identified what may be the optimal length you can able to see the sharp images of the object. So make the person to try to use it on that one. So when you want to use a magnifier, make it first to get it closer to the object, and then bring the magnifier closer to your eyes. So in between the object and your eye, you will be keep on moving the magnifier, try to identify where you can able to get the sharp images. So advantages, you can easy to handle it and easy to carry anywhere. And one of the disadvantages, the field of view will be very smaller, and we need to maintain the distance of reading throughout the paragraph, and you cannot able to do the bilateral activity when you are using this handheld magnifier. Next is a stand magnifier. This is a lightweight, and the person has to use the both eye for focusing into the stand magnifier. And one of the advantage here is the focal distance has been maintained, so you don't need to do any kind of an adjustment. Just keep the stand magnifier on the reading area, and you can able to read it automatically. And this magnifier is one of the advantages, people who are having a tremor or arthritis, because if you have arthritis, you cannot able to hold the handheld magnifier for a long time. It will be creating a pain for you, because sustained activity will always creating the pain for the people with arthritis. And if you're having a tremor, you cannot able to hold the handheld magnifier for a long period of time. Because of the tremor, you cannot able to easily focus. So for this kind of a population, the stand magnifier will be very good, because they no need to hold it and they can able to easily view it. And another disadvantage here in the stand magnifier is the working space, because the stand magnifier is having a very less working space. If you want to do any of the writing activities, it is very difficult when you are using with the stand magnifier, but the reading can be able to do with this one. Next is the bar magnifier. When you are tracing along with reading a book, so the bar magnifier will be very helpful. And telescopic magnifier. So when you cannot able to magnifying the images, or you cannot able to go up to the maximum level of the magnification of the lens, you can able to use this telescopic magnifier. For example, if you are watching the match, cricket match or anything, you cannot able to expand the Dhoni to become bigger, right? So you can use a telescope. By means of telescope, you can bring the Dhoni nearer to your vision, and you can able to see him. So that is maybe the help of the telescope. There are different types. We have a binocular, and we have a monocular telescopes, and also we having the the mirror mounted telescope, or getting along with the glasses you are using. Next is the electronic magnifier. So there are a lot of electronic magnifiers like CCTV or the TV monitor. You can able to use it. And this type of magnifier is best for the people who having a very poor vision. Okay, like not like mild or moderate. Maybe go with like severe categories. So you can able to go with the electronic magnifiers. Nowadays we have this iPad and iPhone will also having this kind of a magnifier. And iPhone is also giving the application of the talking tools. So just show the iPhone near to the object, it will be spell what is that object. It is Coca-Cola or whatever the object it may be, you can able to spell it. So it's easy for the person to use this type of talking devices also. This all will become under the electronics. So you can see the advantage of the electronic magnifier. You can able to enlarge the amount of view just by keeping the images under the scanner. Disadvantage is like the prices. So you can see the images here in the at the right side. You can just keep the reading material under the light, and it will be focusing on the screen, and you can able to magnify it, and also you can able to change the contrastivity of the images. So this is handheld electronic magnifiers. So what we've seen before is like optical devices, and these are some of the non-optical assistive devices, mainly to using for writing and communications. Especially you can use writing guides, like a typoscope can be used for the writing guides and signature guides and the letter guides. Or you can use the board like paper, so to differentiate between one line to another line. You can use the enlarged print papers, and you can use a reading stand if you're not able to hold the paper with you. And you can able to increasing the numbers in the telephone for the person to having the greater visions. And also you can create the contrastivity in the telephone if the person want to show the differentiate between the number and also the telephone one. Or you can add the video calling or audio calling with the telephones. Or you can using the felt tip pen, which will having a very thick ink, so the person when they start to writing, they can able to easily see this kind of images. So you can use this felt tip pen is also one of the assistive devices. So in the kitchen area, we already see this one for a level indicator monitor. This one can especially use it for the hot material, hot water or hot milk or something like that. If you want to pour the cold one, you can able to use your finger to measuring the level also. And you can see the low vision black and white cutting board. You can keep the vegetable on the white part, so the patient can able to differentiate the color of the carrot and also the background of the white because of the high contrast sensitivity. Or they can able to using the measured the spoon for 1 tablespoon or half. It already designed, so they can able to use this one. And these are the few example for the kitchen assistive devices, like a talking kitchen scale, boil alert scales, or long oven mittens, and large print recipes, because most of the recipes will come with smaller letters, so you can able to print a bigger one, easy for the person to know about the recipes and they can start cooking the meal. And for the health management, and we can use the personal care one. You can use the pill monitor with the bigger size name, and you can also use the cutting pillar cutter with the magnifier and the nail cutter with the magnifier, so easy for the person to maintaining their personal care and independence. And these are all the few assistive devices. You can use it for the personal care, like sock holders or a tweezer magnifier, double-sided markup mirror, item locators, just like a talking tools, and iron safety guides, and talking scale or needle threader can able to use it. For the leisure activities, we can bring the big printer sizes for the cards, playing cards. You can increasing the size. For bingo playing, you can also increasing the numbers, or you can using the large remote in order to identifying or changing the channel when they're watching the TV. Or if they're having a difficulty in holding the card, they can use the playing card holders. And few the labels and identifiers, you can using the bumps like this in order to identifying or notifying this is the end and you need to change the directions or something like that. You can able to use this bumps one, or you can use the lock doors, especially use it in the computer to monitoring the common used letters. Or you can use the buttons for labeling in the remote, so maybe the password of the object which you want to open, or you can start and on and off buttons. You can able to do indicators, or you can do the labeling of the daily regular materials like the oil or powder or anything. You can able to differentiate. For shampoo, maybe you can write in a big letter of a shampoo and you put one elastic band, and for the oil you can put 2 elastic band, and perfume you can put like a 3 elastic bands. So just as a marking indicator, by means of locating the bands, they can able to identify, so this is a shampoo, this is a oil, and this is the spray or something like that. They can able to differentiate. So we have to give the appropriate labeling for the appropriate materials. So that's all about the assistive devices you can able to use. And we will be following all the practicing guideline which has been mentioned in the American Occupational Therapists Association. Next, we move on to the evidence base. So what are the activities we are seeing before? It all having a very good, strong evidence-based intervention. So it has been mentioned in the systematic review. You know, systematic review is one of the first level of an evidence-based one. So this systematic review is mentioning when you are using the multi-component approach for the low vision rehabilitation, they will have a very good improvement on the ADL and IADL activities. And it will be increasing the reading, occupation performance, leisure and social participations. And when you are training the person with the eccentric weaving, it is also having a very good evidence base because it will be improving the steady eye techniques and it also enhancing the reading ability of the person. When you are using the problem solving strategies, it will help the patient to improve the ADL and IADL activities. When you are using the technology, the vision specific technology, it will be enhancing the reading performance. And the visual skill training, especially when you're doing the modifications in the home and the environment, and you will train the person in this particular home and environment, it will be giving the very good improvement for the person with hemianospia to improving the reading skill and also the targeting the environment. So all the activities which has been discussed before will having a strong evidence base. So as an OT, whenever you deliver your intervention, you have to be use evidence-based practice. So when you are involved in the low vision rehabilitations, you can able to use these activities because these activities are having a very good evidence-based scientific related evidences. So these are the few scientific related evidence-based articles which I have been found. So when you are using OT intervention, there will be improvement in the ADL activities for the people with a low vision. And when I'm using OT intervention, the leisure and social participation is also getting improved. So it is also the systematic review. And there is an improvement in the reading performance of the person with older when I'm using occupational therapy interventions. And there will be a lot of evidences when we're using an OT as intervention for the low vision people. And there is effectiveness in occupational therapy intervention for people living with low visions. And you can see the improvements of daily activities. Even the driving and community mobility is also getting improved by means of OT interventions. And the leisure and social participation is also getting improved in those interventions. So OT intervention is very good for the person with the low vision rehabilitations when they want to improve in all the aspect of occupations. And most of all this research has been identified from the American Journal of Occupational Therapy. I will find rarely the one article which has been just published in an Indian Journal of Occupational Therapy related to the low vision impairment. They study the correlation between the leisure interest and visual function by Dr. Khanna and Aikat. So they finding the leisure interest for the people who having a low vision by using the NEI visual function questionnaire. And they find that the people who are having a complete vision loss, they having a less interest in doing the leisure activities. And any of this result is not generalized because of the less amount of the population they use. And this shows that in India also we are concerning as an OT in using the visual rehabilitation process. But it has been published in 2015. And of 5 years, till 5 years, I didn't find any kind of other intervention has been used in this particular area. Maybe my search will be limited. Maybe they can publish it in a few other articles or journals or different database, or sometimes they'll do the researches. This is one of the major problems. As a student, when you're doing your bachelor's or master's, you do a lot of researches, but these researches are not able to publish. So when you're not able to publish, it is very difficult to say to the populations that we are working in this particular area and we have different kinds of evidences. So it is very important for us. We have to do the research and we have to publish that research. It will be reaching the populations, people, and also the other professionals to try to know about it one. So it will be clearly says that there will be a lack of awareness. So I think this presentation maybe bring some kind of an eye-opening for the budding therapist, where we can able to increasing our scope of practice. And I find in some recent article written by Dr. K. Mani, when they're doing research among the awareness of an occupational therapist among the physician, especially in Trichy area in Tamil Nadu, they find that most of the physician having lack of awareness related to the practicing of occupational therapy. So it is very important for us to bringing the awareness about occupational therapy practices in the physician aspect and also in the public populations also. So that is the one of the important things mainly I need to convey through these presentations. And these are all my references. And thank you very much for your patience in hearing this presentation. I hope I just giving some kind of justifications related to my topic. I hope the students can able to get some informations, and therapists may be having some kind of an reinforcement or like revising the things. So thank you one and all for your kind participation. So with that, I will end my sessions and open up for questions. If you have any questions related to this topic, please go through it. Thank you.
Thank you so much, sir. There are questions that was sent during the session. So it is on the chat box. So do you want me to read it out or will you be reading it?
I cannot see the chat here. So can you just read it?
Okay, so we also have a time limitation. So whatever is coming first, let me read it. Okay, sorry. How would we assess uneducated patients with low vision? One question.
So it is uneducated or educated is not an issue, because you can able to tell in the way how they're going to be understand the things. Okay, so you can just do the problem solving strategies and try to help them in understanding how in their own way, because we don't have like a specific strategy of written materials given to them. So we can just help them to try to understand and keep them practicing more and more. Keep them practicing more and more. It will be help them to use it in their daily day-to-day life activities.
Okay, thank you, sir. If elder with visual deficit is living alone in a home, what all environmental modification can an occupational therapist do? More than 65 years.
Yeah, mainly you have to do the environmental modification assessment. First, you have to go and assess the environment. Like what I say, like do the lightning assessment and assessing the areas where the barriers they are facing. Maybe sometimes they have a lot of obstacles, and you need to do the home environmental assessment. After you do the assessment, then you can ask the client to prioritize. So which of the barriers we need to be concerned for you more, and then you have to try to do the modification in that one. Especially you can do the lighting modifications and rearranging the home materials, which will be very feasible for the person to use. You can use the contrast sensitivity by changing the color of the wall, or some indications in the daily uses object. For example, they want to use the micro oven, or they want to use different day-to-day kitchen activities. You can just label the activities. For example, oil, coconut, or anything. You can try to label it and give some different contrast sensitivity between the floor and the object, and make sure the floor should not be like more slippery or not like more glossy. If it is more glossy, it will be creating a lot of glare to the patients. So these are all the few modifications you can make, but it's mainly depend on the individual aspect. So you have to go and do the lighting assessment, you have to do the home assessment, and then you try to identify the problems and try to modify it.
Okay, sir. Another question. Are there any low vision rehab centers in India where occupational therapists are practicing and implementing these techniques?
Okay, so for this question, honestly, if I say, I'm not aware about this, because they have low vision rehabilitation. Even in the optometrist and ophthalmologist, when they are involving in the low vision rehab, I know that Kendralia Visual Rehabilitation Center, they have the low vision rehabilitation. Mainly they having optometrists and ophthalmologists and opticians are working in that particular area. But I'm not sure whether the OT will be in their area or not. But even the ophthalmologist also saying that in one of the articles they mentioned that the low vision rehabilitation is having lack of awareness. So the main thing is here, we need to create the awareness first in order to overcome these issues.
Okay, sir. What is our OT role in school-going children with low vision?
Okay, so children, because here we are targeting more about the adult population and geriatric population. Even the children, sometimes they will have profound blindness, or sometimes they have a low vision. So I was working in the low vision rehabilitation school, the Clark School in Mylapore in Chennai. I was working in the Visual Rehabilitation Center. I find the school is having a lot of adaptive and assistive devices are there. So they will be teaching a different braille systems for the people to educate. And for the low vision, they will giving a lot of optical devices. So as an OT role, when you want to concentrate more about the academics and the learning aspect, you can able to prescribe appropriate optical low vision devices and try make the child to be get to use to that one. So that is the one of the way we can able to do it.
Okay, sir. Is there any scale or assessment that can be used for children with low vision?
So already we can check the optical assessment for checking the visual acuity and visual field problem of the child. And you can also use a visual screening questionnaire. And I mentioned in the presentation, there is a Christopher packet visual acuity charts are there. We can able to use that chart for the children assessment. Apart from that, we also using this visual perception assessment, VMI and other things are there for improving the writing and academic skill for the children. But most probably I will be concentrating more on the geriatric populations. So the assessment, what I mentioned here, the few assessment can able to use it. For example, COPM can able to use it for the children. Some of the visual functional questionnaire can also be checked with the proxy version. Instead of asking the children, you can asking the parents, what are the visual deficit problem your childs are facing. So based on that, you can do some adaptations and modifications for the children, even in the notebook or in the book where they are reading. So you can giving the optical devices for reading for the children.
Okay, sir. For AMD patients with central vision loss, what is the best intervention to give? Visual enhancement techniques like eccentric viewing training to fix peripheral retinal locus, or to give electronics aid like portable vision enhancement devices?
Okay, so as I mentioned before, so not all the patient is getting benefited by means of going with this kind of an eccentric training. It mainly depends upon each patient. So you have to use the eccentric training along with the devices, the optical devices. So it will be help them to get more clear informations. So we can able to use both together, eccentric training plus optical or electronic devices.
Okay, sir. What is the intervention for hemispatial neglect?
So you need to come to understand the hemispatial neglect is like there is a lack of information carried from the affected environment. So as I mentioned before, you can using the prism glasses. So try to gather the information from the unaffected side, bring it to the non-affected side. And also you can give the lot of training. As an OT, we are dealing with the stroke patient. You can give a lot of training in order to go to correcting this neglect problems. So neglect means automatically it will go with the perception problems. So that means you have to go with the cognitive rehabilitation process for this kind of an issue, apart from this low vision rehabilitation. So you need to be combined together. You can use a prism glass, you can give the training, and also you can bring all the environmental things which will be related to their unaffected sites.
Okay.
And you can do some contrast changes in the dressing, maybe the bright colors, which will also help them to use it. So mainly the spatial thing is like you need to move the spatial environment to the unaffected side.
Okay, role of OTs in amblyoptic kids.
So mainly you can do the patching training, try to focus the lazy eye into the functional activities. And if they're having prolonged visions, then you can able to give the optical devices in order to improving the visual field and also the visual acuity. Mainly, this will having a visual acuity problem. You can go with a lot of electronic devices if it is not corrected. One of the best technique is like a patching technique, make the person to focusing on the affected side to be more.
Okay, sir. Would we be using Braille with low vision patients, or is it only used for total blindness?
For a severe impaired low vision patients, you can able to use this kind of an Braille system. That will be also, it will be good adding more information for the patient. You can able to use it.
Okay. Could you explain few words about cortical blindness and management for that?
As I mentioned before, we are not seeing the object through our eyes. We are seeing any object through our brain. So when there is a total damages to the cortical, the visual cortex, so a person will be more prone to get this kind of cortical blindness. So maybe we can try to use it on the unaffected side, try to maximizing the information from the unaffected sides for this one, because cortical blindness is sometimes difficult to correcting, because I mentioned you need to correct the vision before it affecting the optic nerve. So if the optic nerve is getting affected, it will lead to perception problems.
Okay, thank you, sir. How do we assess sensory issues in children with low vision?
Okay, so children with low vision, and it is like a question apart from my presentation, because my presentation is more related to the adult populations. Yes, but we need to be considering about the sensory issues, because you see the because I was working with the visual rehabilitation centers, I can see they will be concerning the sensory issues, like giving a tactile, proprioceptive and kinesthetic sensation to the children. Along with that, they will also adding the low vision devices for them also. So we need to be address both.
Okay,
so no
sir.
need to be neglected. Yeah.
For treating children under 3 with sensory issues, can they be exposed to lights against a dark background which increases the brightness?
Sorry, can you repeat?
For treating children under 3 years of age with sensory issues, can they be exposed to lights against a dark background? Is it safe to expose them to lights in dark background? I think is what she meant.
So actually this is not related to the topic, but when you want to give the bright light to the children, we need to be see whether the child is having any visual problem or not. If they having like high contrastivity to the lightning, and this bright light may causes some glare, and it will may causes irritation to the child. So we need to be reducing the glare and try to give the light appropriate to the child vision abilities. If the child is having the accommodation properties, I think there's no problem in you giving a bright light, because child can able to adapt. If the child is having difficulty to adapt, then we need to be considered about changing the light contrastivity.
Okay, sir. I'll ask one more question because of the time constraints. Can you please explain about any driving tools that are available for the person with low vision?
Okay, so the driving is another important area, because the driving rehabilitation is a separate area apart from this visual rehabilitations. We have a lot of simulated tools are there in order to improving the driving skill for the patients. And there are special assessment like indoor assessment and outdoor assessments are available for the driving rehab. So we need to train the person in the indoor rehab by means of using simulations. After the person is getting a good skill in the simulation one, then we'll be take the patient to do it on the outdoor training. So we can able to do some of the low vision adaptive devices in the car, like reducing the glaring and increasing the contrastivities. So mainly there will be a lot of environmental modification and designing in the car has to be done for the training, but that will be another big area. What I given here is like is a drop in the ocean, like a few things about the low vision rehabilitation. But the driving rehabilitation is a separate part, and yes, we have a different separate assessment are there for the driving rehab, like simulation task, and we can use a CodeNAP as to checking the cognitive ability of the person, and we can use a few of the visual acuity, visual field issues also there in the driving rehab.
Okay, thank you so much, sir. Would you like to share your email ID with the participants? If they have further questions, they can contact you. If you are okay with that, then
yeah, no problem. You can just share my informations. So I am ready to giving clearing their doubts.
okay, thank you, sir. Would anyone like to share your feedback regarding the session in a few words?
Afternoon, sir. Myself, Moses. I'm doing my occupational therapy third year in Sri Ramachandra Medical University. First of all, thank you very much for this fantabulous presentation, sir. It was really great. I just don't want to give feedback about the presentation. I just want to talk about how I felt about the presentation. The professionalism and the standard of the presentation was really very high, sir. That was great. And at the starting, I had love on the two things, the two phases we had, like you just dig into the scientific stuff, as well as you had the social things they face in their life, day-to-day life, and the factors which influence the environment. That was really great, sir. Like the currency colors, like light modulation, that was really great, sir. Afterwards, I just talked about the AMD. That was so nice. And the important topic which I felt is like the diabetic retinopathy, which the old people commonly face. That was really great, sir. And the glaucoma, that was seriously nice. And then you just told us about the common concern that we should have on the environment. So it was really nice, sir. On the total, I would say that it is a pack of informative session that was really nice. We look into more the presentation from you, sir. Thank you much.
Thank you, Moses, for your feedback.
Thank you, Moses. Okay.
Sir, good afternoon, sir. I'm Mitra. So from Sriya. I'm really eagerly waiting for your webinar, sir. Thank you for your clear view on low vision rehabilitation perspective, sir, which I had not known. And it was a very informative and I gained a lot of knowledge about that, which I can make into my practice. So it's an excellent presentation, sir. Thank you. And I would also like to thank our HOD, Dr. Raghuram, sir, and our faculties who provided this wonderful opportunity for us, sir. Thank you, sir.
Thank you, Mitra.
Thanks, Mitra. So by this, we have come to the end of our webinar. This was the fourth webinar that was organized by the Occupational Therapy Department of Sri Ramachandra in association with Tamil Nadu branch of IOTA. And sir, I must say there are messages saying thank you from so many people in the chat section. I wish you could see it later. So I would like to formally thank the administration of Sri Ramachandra Institute of Higher Education and Research and Tamil Nadu branch of IOTA for giving us this opportunity. I extend our gratitude towards Dr. Jayachandran for agreeing to speak to us and also for sharing his experiences and knowledge with us. I especially liked, like Moses said, where you mentioned the common concerns with the low vision clients, and it was an eye-opener for many of us who didn't know much about low vision rehabilitation. I also thank all the participants for patiently attending the webinar from various places. Thank you for your cooperation and responses. Thank you for making this session very interactive by asking questions. And a special mention to our HOD Raghuram sir and Assistant Professor Sundareshan sir for coordinating and organizing all these seminars and the upcoming webinars as well. Last but not the least, I thank the staff and students of Sri Ramachandra Institute of Higher Education and Research for their support and cooperation. Thank you. Raghuram sir, do you want to say something?
Yes. Thank you, sir. Thank you for this detailed session. You have spent a lot of time with us, though it is a webinar that what we felt like it is a direct class. So really, what is a very good session, sir. Definitely, you will get a lot of feedback from the Indian people. Thank you, sir. Thank you so much.
Okay, thank you. Thank you so much for providing this opportunity for sharing the information.
So thank you everyone. You can leave the meeting. So I will get back to you, sir.
Okay, thank you. Thank you for everyone. Thank you. Bye.